I'd like to spend the next few minutes to give you an update on the proposed cuts that Medicare is planning on implementing next year. I don't have any financial disclosures, although I am a member and advisor to the RUC committee and the practice expense subcommittee that you'll be hearing a little bit about later in my presentation. So what happened? Back this summer, not too long ago, on July 13th, Medicare made the announcement that they have certain policies that they want to put in place for physician fee schedule for the upcoming year. Now, there were a total of 29 sections to this, 1,700 pages, but the first one that they listed was practice expense relative value units and how those were going to be changed. And indeed, that's what potentially can affect all of us. So what is practice expense RVU anyway? Well, practice expense is divided into two components. The direct expense, which is the clinical and non-physician labor, nursing staff, disposable medical supplies, devices, and fixed equipment, and also indirect expenses, such as your secretarial administrative staff, rent for the office, other associated office expenses. As you can imagine, this could be complicated to try to figure out for the entire country. Originally, practice expense calculations were based on the average charges that were allowed back at that time. Then beginning in 1999 with a 4-year transition, resource-based calculations were begun, and specifically a top-down, meaning that they used a clinical practice expert panel and the AMA monitoring system on socioeconomic factors to calculate costs. In 2007, this was updated again with another 4-year transition using a bottom-up methodology, meaning they started looking at actual costs, invoices, and advice from the RUC Practice Expense Advisory Committee. This is not a static process, and CMS is required to review these RVUs at least once every 5 years, but annually for codes that potentially are misvalued, or at other times when there's potentially misvalued codes that need to be adjusted and were identified. Budget neutrality is a very important concept that plays a significant role in this topic. And that means that any changes to any RVU that changes the total cost to Medicare in physician payment only, of greater than 20 million essentially is not allowed. Adjustments have to be made so no changes cost more than $20 million. So how is this actually implemented? Medicare pays for the cost of a service based on 3 components: the amount of work the physician does, liability insurance, and practice expense that we've been talking a little bit about already. When you take a look at the distribution of this, liability insurance is only 4%. Physician work accounts for just slightly more than half of the total cost, but practice expense is a huge component, almost as big at 45%, and last year was about $11.5 billion just for Medicare payment to physicians. But once each individual component of that is assigned a relative value unit, there is another adjustment called the Geographic Practice Cost Index, or GPCI, which effectively takes into account the fact that it's more expensive, say, in California to practice than in Iowa. Then these are all added together to come up to the total RVU that the physician is paid for. But not quite. Before that's done, there's another conversion factor that's put into play. Now, this conversion factor can be quite complex, but essentially it's an adjustment to make sure that the total cost for Medicare is kept neutral. It doesn't increase. So the conversion factor in 2020 was $36.09 for each RVU. Last year, it was decreased mainly because the reimbursements for E&M was increased. Therefore, the conversion factor was needed to keep this total cost down. So it decreased to $34.89 or 3.3%, which turns out to be quite a lot of money. Fortunately for us, there was congressional action, and US Congress gave an additional $3 billion to CMS to prevent implementation of that decrease in the conversion factor. But for this upcoming year, without new legislation in 2022, this conversion factor goes down even more, another 3.75%. Significant for all of us individually. But wait, there's even more. There's been a series of updates into the supply and equipment prices over the past 4 years, and that too will go into effect starting next year. But most importantly, and what's being proposed for next year, is a change in the clinical labor rates. In other words, what is being assigned for payment to those nursing and associated staff. Now, it was last updated in 2002, so this sounds reasonable, and CMS is proposing to use the Bureau of Labor Statistics 2019 data, that's the latest data available, beginning next year. So for example, the labor cost for a medical assistant would increase by 50%, a registered nurse 67%, radiology tech 68%, and a vascular tech will be almost double. But what's wrong with this picture? Isn't it appropriate to update the labor cost from 2002? I mean, that's almost 20 years ago. And isn't it appropriate to use your best available data for these expenses and to keep things updated? Well, yes, of course it is. But these increases in these assigned values had nothing to do with what's actually being paid to your office staff. Medicare doesn't give you a separate check to pay for office staff. It's the physician that pays his office personnel. And no office staff is being paid at 2002 levels, otherwise you'd have no one working for you. In addition, there are some real technical issues when you take a look at these proposed changes. So for these labor updates, CMS is proposing to use mean values. But median values are used everything else in calculations for those RVUs. Why? Because mean values can be very much affected by outliers, extreme ranges. In addition, when you take a look at the actual labor cost, 12 of the 32 staff types isn't going to be using BLS data, but other sources, undefined. In addition, 14 of these staff types don't have an exact match in the Bureau of Labor Statistics, so they use a linkage to other positions. Which other positions? We don't know. That hasn't been told to us. It hasn't been made public. And finally, in calculating fringe benefits, they're proposing to use the fringe benefit adjustment from 2002, which is much higher than the one in 2019. So why not use the correct one? There's other striking components to this. Through budget neutrality, as we've already discussed and mentioned, the total pie is fixed, but so is that section of the pie linked to practice expense. That's fixed as well. So increasing labor costs about 30% or $4 billion for next year necessarily decreases the amount of money that's assigned for equipment and reimbursement for your supplies. So why does that make a difference? The total pie and the total part of the pie for practice expense is fixed. Well, in order to maintain that fixed one, there's another correction factor, a scaling factor that's going to decrease by 24%. Okay? And what that means is that for your supplies and equipment, Medicare will reimburse you only 44 cents on the dollar instead of 59 cents for these costs in the office. So if you do procedures with equipment and supplies, as most venous specialists do, you will get paid less. This, for any business, is unsustainable. When you look at the relative value units for practice expense then for our common office venous procedures, you see that it ranges from 7% for phlebectomy, which took a cut in these last few years, to up to 24% for radiofrequency ablation. These are significant effects, and these incorporate about 80% of the activities in most venous offices. Taking a closer look now specifically at the supply costs for these various venous procedures that you see listed here, and what CMS proposes to pay with these adjustments, you'll see that the actual amount of pay isn't even going to pay for your supplies. So therefore, within the general category of practice expense, there's not going to be any money left to pay for clinical labor, other equipment, or indirect costs. When you convert that not just to the practice expense component, but to the total payment that CMS will pay, this is what happens. RFA goes down by 23%, lasers 16%, MOCA 22%, adhesive occlusion 28%, phlebectomy 8%, and venous stenting or IVUS gets cut by 22%. So these total direct cost, direct payment reductions are significant for any practice. What are the secondary effects of doing this? Not just the effects on venous practices. Well, effectively what you're having is a redistribution of payments to primary care specialties that don't have a high cost in equipment and supplies. And CMS admits this. Specialties with a substantially higher direct cost attributable to labor would experience significant increases. So for next year, family practice gets an increase of 2%. But vascular surgery gets a cut of 4%, interventional radiology 5%. That's globally, taking into account everything that each specialty does. Because of this, the AMA is officially neutral on these proposed changes for next year, not lobbying against it. And the House of Surgery as a whole isn't really very focused on this as well. But wait, there's even more. Okay. We've talked now broadly about the labor cost affecting us at -4%, not just the venous, okay? But there's other associated costs that are going to be cutting in for next year. A conversion factor making up for the increase in evaluation and management codes from next year will induce a decrease of 3.75%. The Budget Neutrality Act, which says that the total budget can't increase, and if it does, everybody gets a 2% cut, affects Medicare. And because there was unfunded COVID payments of last year that gets distributed to everybody, that's another 4% for physician payments. So overall, if nothing is done, we get a decrease of 13.75%. But specialty-specific effects, like we've already talked about to some degree, are more relevant to us. And so specifically, I've already reviewed what happens in the office. But isn't this interesting? Because it's not the same thing that takes place in ambulatory surgery centers or the hospital, because they get paid out of a different bucket of money, not the ones for physicians. So if you're doing an RFA or laser, you actually get reimbursed more in the ASC. And take a look in the hospital. They have cuts, but they're very small compared to what happens in the office. So because of the lesser effect on ASCs in the hospitals, neither they nor insurers are really lobbying very much against these changes. And finally, let's keep in the back of our minds the historical context of inflation. These are absolute dollars, but in this nice study from the Mayo Clinic that came out just this year, taking a look at the value, the purchasing power of the money that we're actually paid, as you can see here, RFA, the amount that we're paid now is 34% less, and for phlebectomies, 50% less than a decade ago. And overall, for venous procedures, 42% less. So it has not been a good trend for venous treatments. What impact will this have in the future? Well, we can get some appreciation of that looking at what happened in 2017 when CMS cut vascular access procedure codes at vascular centers. When they cut it by 39%, by the next year, 20% of these centers closed, and there was a 30% decrease in procedures being done at access centers. Similar things are possible for venous procedures if something is not done. So in conclusion, the proposed changes that we're talking about are significant and especially likely to negatively affect venous practitioners and office-based procedures. There's been a divide and conquer strategy here where there's an opposition between hospitals and payers and physicians, primary care versus specialists, and even within specialties, depending on the type of patients that are seen and the treatment locations. This will, however, have a very deleterious effect on patient access, the quality of care, and overall healthcare costs, as these procedures would be moved outside of the office. Now, we've spoken and sent letters to CMS. We will see what the final decision on labor costs will be when they come out with their decision in November. But we still have time, and we need to be very involved with congressional action to prevent all those other costs that I talked about. So I thank you very much. The other presenters this morning will be talking about some of these other activities, and I hope I've provided you with some insight into this process. Have a great day.